Good morning, everyone. I welcome you once again to yet another edition of the Retina series, anchored by the Kunle Hassan Eye Foundation Academy. This is the third lecture in the series. The topic we'll be looking at today is on the basic concept and interpretation of the Fundus Fluorescein Angiography, the FFA. I'll quickly go through the program. So I'm currently doing the introduction. After the introduction, we'll have the presentation from the speaker, the interactive session, and then the closing remarks. I'll give a brief introduction of the Kunle Hassan Eye Foundation Academy. It is a member of the Eye Foundation Eye Care System, formerly known as the Deseret Community Vision Institute, which oversees the training for ophthalmology residents, fellow and middle-level ophthalmic practitioners. Under the Eye Foundation Eye Care System, we have the Eye Foundation Hospital Group, the Summit Healthcare Pharmaceutical, the Eye Shop, and the Summit Vision Group. Our speaker today, Dr. Olufemi Oderilo, is the past chairman of the Retina Society of Nigeria. He is qualified as a medical doctor from the Obafemi Awolowo University in 1993. He commenced his residency training as one of the pioneer residents in Eye Foundation Hospital in 1997. He had his clinical attachments during his residency training at the Tenet Institute of Ophthalmology in Glasgow, Scotland. He became a fellow of the Royal College of Surgeons in 2002 and obtained a diploma in ophthalmology from the Royal College of Ophthalmologists, London in the same year. He is a fellow of the West African College of Surgeons and has a master's in clinical research from the University of Liverpool. Dr. Oderilo completed his subspecialty training in vitreoretinal surgery in Eye Foundation Hospital under the tutelage of Dr. Adekunle Hassan in 2004. He's a recipient of the AFA Avo Host Research Award in USA in 2010 and has had many observatory and clinical attachments in different countries. He is the current medical director of the Eye Foundation Hospital Group Ikeja, as well as the director of research under the Kunle Hassan Eye Foundation Academy. He's proficient in various retina and cataract surgeries. He's presented several papers both locally and internationally. He is the present ophthalmology editor of the African Vision and Eye Health Journal. He's a member of the American Academy of Ophthalmology since 2002, and he is a founding member of the Retina Society of Nigeria. In our past lectures in the series, the first lecture was on advanced retinal OCT interpretation. The second lecture was on the interpretation of retinal optical coherence tomography angiography, which is the OCT angio. So today, Dr. Oderilo will be speaking on fundus fluorescein angiography, the basic concepts and its interpretation. Thank you very much. Just to run quickly through a few house rules, we ask that you please keep your microphone muted and keep your cameras turned off. This will enable us to have a seamless lecture and we'll be able to engage well with the speaker. During the question and answer question session, you can either type your questions in the chat box or raise your hand. Thank you so much. Dr. Oderilo, I welcome you to take on this lecture. Thank you.
Good morning, everyone. It's always a pleasure to have the opportunity to share what the little I know with the future specialist in retina practice. Can you see my cursor? Can you see it moving? Latifat, I just want to know.
The cursor is not moving. Good morning.
You can't see the cursor at all.
No, it's not moving. No, sir, I can't.
So, okay. But you can see my slide.
Very well.
Yes, I can, sir. Yes,
Okay.
sir, it's clear.
We'll go on and we'll see how we can get it done. So, good morning once more. Thank you for spending your early Wednesday morning to learn a little more about retina. The first 3 sessions we've had in the KHEFA lectures has been on basic investigatory concepts in retina practice. From next month, we'll be having more of clinical presentations. We'll be addressing specific diseases in retina, and also we'll be looking at updates of information in retina practice around the world. So we'll be inviting a lot of other retina specialists from all over the continent and all over the world to come and teach us so we all can learn. So please make your time, put it in your diaries, and make time to be with us. So we're looking at fundus, fluorescein, angiography, basic concepts and interpretation. This really comes in as a special request from a number of residents who would like to know this. For those who attend update courses, you will have seen me take this course so many times. I think I must have taken it well over so many times in different, so it will be familiar to some people, and to some people it's going to be new, but this is basic knowledge for retina practice that we really need to know. A lot of people say fluorescein angiography, FFA, is out of reckoning, it's no longer relevant for retina practice. It still has its place, and we are going to look at the areas that we are able to use fluorescein angiography these days. So I have no financial interest. Information for this presentation was obtained from different sources, including daily clinic patients, webinars, word rounds, unpublished and published articles. So FFA is meant to be used as an investigational tool. Adequate history, examination, and other ancillary investigations are required to make the correct diagnosis and to monitor treatment outcomes. And this is always a caution we say: we treat patients and not FFA scans. So what exactly is fluorescein angiography? Two things we need to determine in this is angiography and then the characteristic of fluorescence, which is what gives the name fluorescein. The fluorescein angiography is a fundal photography performed in rapid sequence following intravenous injection of fluorescein dye. It basically provides information of flow characteristics in blood vessels in the retina. It records fine details of retinal pigment epithelium and retinal circulation, and it gives a clear picture of retinal vessels and assessment of their functional integrity. So the substance fluorescein, when you say fluorescence, when you say a substance has a characteristic of fluorescence, what it means is that it absorbs light at a lower wavelength and emits it at a longer wavelength. So here, fluorescein is a substance that absorbs light coming at about in the blue range 490 nanometers, and it emits it in the yellow range 530 nanometers. It's metabolized by the liver and excreted by the kidney, and within 24 hours, most of the dye is excreted. So you need to tell your patients that within 24 to 48 hours after dye injection, their urine is going to be fluorescent yellow. This is so characteristic. If you don't tell the patient is going to be scared when they go to the restroom and see the color of their urine. So it's very important to inform them that their urine will be fluorescent yellow. Usually 24 hours, but we say 24 to 48 hours. Now, the sodium fluorescein has a molecular weight of 376 daltons. It is 80% bound to plasma albumin. So what we see during angiography is just 20% that is in circulation. What we do, basically, there are generally two main concentrations of fluorescein we see around: the 10% and the 20%. And usually what we use mostly is the 5 mils of 10% is injected into the veins, and then the photograph is, you have to have a fundus photograph that has facilities for fluorescein angiography, that is the filters that are present. And because different filters, the blue filter and the yellow filter. Once a decision is made to undertake FFA, you need to make a preparation for the administration. You need to get resuscitation material available. you should have your standard resuscitation material, the ample bag, atropine, adrenaline. You need to have the basic facilities that you need to resuscitate a patient available. Of course, you need to take a written consent, and then the nurse should be, depending on the structure of your organization, you need to notify the department that is going to have the patient coming to them. We have a different procedure department where we do such procedures with nurses and doctors, and we say that usually it's doctors for us, and that's the advisable thing. The injection of the fluorescein should be done by doctors, and I know in some areas they allow nurses to do it, but for us doctors do the injection. So the dose is usually 7.5 milligram per kg, and you can calculate that based on the volume, either you are using a 20% or a 10%. Sometimes fluorescein can be given as an oral drink administered with an icy citrus drink. So the images are taken, and after the images, the patient is still kept for at least 1 hour to monitor them for adverse events. What are these adverse events? Those which are very common is nausea. Nausea is most of them will have nausea. About 10% will vomit in addition to the nausea, and usually treatment is not needed for the nausea and the vomiting, and it usually clears out on its own. But the ones one really needs to pay attention to is the vasovagal syncope, and for that is the patient is in extreme bradycardia. IV atropine may be needed. Anaphylaxis may also occur in varying degrees, leading to bronchospasm, urticaria, rash, hypotension, and one has to follow the resuscitation routine. And like I said, you always have your chlorpheniramine, hydroxycortisone, adrenaline available. Very rarely there could be cardiac and respiratory arrest, and treatment would involve cardiopulmonary resuscitation. So it's extremely important that when you are injecting fluorescein, you have your resuscitatory materials around, and you have your knowledge of your basic resuscitation protocols. And this is very important. I'm sure whenever the college comes to look at most places that do this, they always will ask for this. What happens when the fluorescein comes into the retina? They are basically the structures that determine its distribution are the vessels, and we have more information when we think of OCTA. We have more information to tell us that there are different vascular plexi that are divided into 3. But on the angiography is only the superficial vascular plexus that we can see, and in that the 2 things that determine mainly is the retinal blood vessels endothelium and the RPE tight junctions. These do not allow dye to pass through except they are abnormal, and there are basically 2 circulations that can easily be seen. The retinal circulation is more obvious than the choroidal circulation in fluorescein angiography. In ICG, we can see better of the choroidal circulation. So fluorescein also can get into the aqueous, and it can get into the vitreous if there are leakages over time. The optic disc, myelinated nerve fibers, and hard aggregates appear progressively more pseudofluorescent through the course of an angiogram for this reason. So the phases of a fluorescein angiography, the first phase actually will be when it gets into the choroidal circulation, because it gets into the choroidal circulation before it gets into retinal circulation. Hello? You can still hear me? Okay.
Yes, sir.
Oh, thank you.
Yes, okay.
Thank you. So basically in the retina, the 4 phases that we see is the arterial phase. In the arterial phase, you can see the dye in the arterioles. In the venous phase, there's the early venous phase and the late venous phase. On the image on the right, you can see the early venous phase, and this is what is called the diapidic flow. in which you can see there's no dye in the center of the vein, but there are two peripheral lines of dye flow. When you see this is usually the early venous phase. When it's the late venous phase, both the arterioles and the venules are full of dye. In the late phase, the dye becomes less obvious as it's being pumped out from the eye. It's important that we take note of these four phases. So this really helps us in determining a lot. One of the main informations we can get, especially when you are looking at vein occlusions, is to distinguish between collaterals and new vessels. And so collaterals usually will not leak, whereas new vessels will leak. You can see this image, you can see this vessel. If you are looking at it on fundus examination alone, you might not be very certain if this is a collateral or this is a new vessel, and it's important for you to identify, because for instance, if you are going to do laser for a branch retinal vein occlusion, macular edema, or if there's a lot of ischemia, you do not want to treat collaterals because collaterals are doing you a favor, whereas if they are new vessels, it's an indication that the ischemia is significant. So a fluorescein angiography will help to differentiate between both, and we can see these are collaterals, they are not leaking with injection of the dye. I will go into further details. Now, indications of angiography, let's look at diabetic retinopathy. It's one of the more common reasons why I want to do an angiography. It helps to detect any significant macular edema which is not clinically obvious. It helps in locating the area where the edema is concentrated, and this helps for laser photocoagulation, especially if you are going to be doing a grid pattern. It helps in differentiating ischemic from exudative diabetic maculopathy, and it helps differentiate from IMAs and new vessels. We saw that just now. Another indication is age-related macular degeneration. It helps us to locate where the subretinal choroidal neovascular membranes are, and it helps us to characterize it. We'll talk about that. Other indications are locating subretinal choroidal membranes, locating abnormal volve vessels, locating the breakdown of RPE, and helping the diagnosis of other disorders like inherited Stargardt's disease. So when we are doing an analysis of a fluorescein angiography, there are three things that are important that we need to look at. We need to look at the frame of the images in a sequential way. We need to analyze it anatomically, and we need to analyze it morphologically. So if you are looking at it in a sequential way, that you are using time, and you are seeing when it goes into this flow, when it gets from the retina to the choroidal. When you are looking at it anatomically, of course, you are looking at the choroid, the RPE, and the neurosensory retina. The morphologic characteristics are usually two. It's usually that the dye causes hyperfluorescence or hypofluorescence. I said usually two because there's autofluorescence and there may be abnormal fluorescence. But the two abnormals are hyperfluorescence and hypofluorescence. Hyperfluorescence is when it appears more brighter, whiter, and it goes beyond the limits of the tissue that we are looking at. Hypofluorescence is when it appears darker, as the fovea usually will appear. So we look at abnormalities in time. That's the time it takes for it to move from the point of injection into the eye, and we'll also look at the morphologic distribution, as we have said. So looking at morphologic patterns, this is very important. I said there are basically two abnormal morphologic patterns. One is hypofluorescence. One is hyperfluorescence. One is blood pigment or hard exudates, or where there's a filling defect, that is, there's a circulation abnormality, there's a place where the dye cannot get to, although it is supposed to get there. In the hyperfluorescent patterns, there are four of them. Basically, there could be leakage of dye from abnormal vessels like choroidal neovascular membranes or new vessels. There could be pooling of dyes in abnormal potential spaces, as will happen in RP detachments. There could be staining of the blood vessels that are abnormal, and there could be autofluorescence. Autofluorescence is without a dye injection, there is the appearance of the tissue in a fluorescent pattern. So let's look at this flame very well. It gives us a diabetic retinopathy, and it gives us different patterns that will help us to know what I've just described. So in one, you see this hypofluorescent pattern. One on your right, you see hypofluorescent pattern, and that is because of a retinal hemorrhage that is obstructing underlying choroidal fluorescence. This is different from number 2, which is the hypofluorescent pattern as a result of ischemia, poor blood supply, blood not getting to this area. Then we go to the hyperfluorescent patterns. We see a sort of mild pooling of dye in number 3 as it happens in microaneurysms. In number 4, we see leakage of dye as it happens in neovascularization. In number 5, we see IMAs. These are abnormal connections between arterioles and venules, and they do not leak. And this is very important. And then you also look at the number 6, which is a slight pulling of the dye in the vessel walls, and that happens in things like venous bleeding. And these are characteristics that we see in diabetic retinopathy. So let's look at some of the, to get used again to it. So hypofluorescent pattern, this is decreased fluorescence as a result of obstruction of underlying choroidal fluorescence. So this may happen in a nevus. You can see this nevus here, and you can see it's obstructing the transmission of the dye. And also we look at this, it also happens when there is a central retinal artery occlusion and there's no blood going into the vessels. No blood going into the vessels at all. So this also is a cause of hypofluorescence. Hyperfluorescence, window defects, a perfect example is a macular hole. In the center of the macula, there's a hole, and that creates an enhancement of the underlying choroidal fluorescence, and that's what we see. There are other things that can cause these window defects when there are atrophy of the RPE, in ARMD, in geographic atrophy, in ARMD, myopia is another one that can cause such, angioid streaks, and a number of others. Now, this is pooling of dye. Pooling of dye in a potential space. Here it forms a petaloid pattern, and that's what we see in cystoid macular edema. The dye pools within a potential space in the retina. Now, there could also be leakage of dye from the edges of the vessels because the vessels are inflamed and abnormal, and this can happen in sparse planitis, vasculitis, and posterior uveitis when the vessels are inflamed, and you can see the dye leaking out of the periphery of the vessels as they flow through it. So staining can also happen with things like drusen. Drusen gradually over time tend to absorb the dye, and they show a seeming hyperfluorescent pattern that results in what we call staining. So leakage from abnormal vessels, there's other abnormal vessels, fundal tumors, malignant melanoma can also cause leakages when you have their sentinel vessels, and also when you have disorders like Coats disease that have abnormal vessels, you can see the leakage of the dye from them. This is the appearance of autofluorescence, and you can see no dye has been injected, but this optic distrusing, the fluoresce. Now, in diabetic macular edema, the structural OCT in combination with fluorescein angiography will be the most sensitive to detect DME with intraretinal fluid accumulation in the presence of leakage. So it's important that now we can combine modalities. We have OCT angiography, we have FFA. We can combine modalities to give us more detail about any patient that we're evaluating. Don't forget the established definition of macular edema. The OCT, this actually is a clinical definition, but the OCT helps us to identify it better. Now, the OCT in diabetic macular edema can also help us to classify it into what type of leakage is going on, focal or diffuse leakage. In focal leakage, you see well-defined areas of leakage as will happen in microaneurysms. The FFA will clearly show the source of the leakage, whereas in diffuse is poorly demarcated, it's widespread, and the FFA will show widened intercapillary spaces with diffusely dilated capillary bed and diffuse leakage. So this is something else that FFA will show us. You see here there's an enlargement of the fovea vascular zone, and this is a diabetic patient with actual macular ischemia, and that helps us to be able to put a prognosis to the patient, because edema responds well to anti-VEGF, but ischemia less likely. Again, there's a characteristic that we see in fluorescein angiography for laser scars. So it shows a central area of hypofluorescence with a surrounding halo of hyperfluorescence. A central area of hypofluorescence with a surrounding halo of hyperfluorescence, what we see as the FFA description and the FFA characteristic of post-laser. So you can see these lesions and you can decide with an FFA that this is a laser treatment and nothing else. Proliferative diabetic retinopathy, branch retinal vein occlusion. You have a fluorescent patterns. So we can see this is a patient who had a branch retinal vein occlusion presented. If you look at the fundus picture, it looks like the patient is really very okay, but he kept complaining of reduced vision, and so a fluorescein angiography shows us that he has this area, this quadrant here of, he previously had a branch retinal vein occlusion where the hemorrhages has cleared out, and that's one of the uses of an FFA. This information is almost characteristic. The only other place you can see it is on an OCT angiography. So this is also a BR view, an inferior hemispheric BR view. You can see what we described earlier, the blood flame-shaped hemorrhages causing the hypofluorescent pattern, and if you look at the image on your right and inferiorly, you see that the vessels are leaking because they are abnormal, and you can see the staining of the periphery of the vessels, and this shows the branch retinal vein occlusion. Now this is another one. You see the hemorrhages causing hypofluorescence appearance. Central retinal vein occlusion. One thing like branch retinal vein occlusion that is important is to be able to distinguish between and if it is not ischemic, because the protocols for each one of them differ. So these are the acuity is usually low. There's usually a relative afferent hemorrhages, presence of multiple cutting. These areas of capillary non-perfusion, 7-field fluorescein angiography. That's the definition, and this was given to us by CRV study, although it's quite an old study now. And so what we see characteristically, we see, like you can see on your right, you see that there's a masking of the underlying fluorescence by intraretinal hemorrhages, and then you see the delayed intravenous transit time. You really have to pay a lot of attention to it. What happens is that for each of the frames, you can see the time at which the frames were taken, and you have to pay a lot of attention to it before you can really say there's a delayed transit time. And then in the third one, we can see the leakage at the optic disc head, which also happens, and late staining of the vessel walls. Like I said, abnormal vessel walls will stain. So fundus fluorescein angiography is so very useful in related macular degeneration. It helps us to describe the type of choroidal neovascular in the exudative type. So what we see, first of all, depending on the size of depending on the size of the choroidal neovascularization and its location relative to the center of the fovea. So if more than 50% of the whole neovascularization is of the classic type, then we say it is predominantly classic. When less than 50% is the classic, then it is minimally classic. So extrafoveal lesions are greater than 20 microns from the center, juxtafovea are less than 200 microns from the center, and subfovea involve the center of the fovea avascular zone. So we look at, I'll give some examples so we can understand it better. So basically, choroidal neovascular membranes will show as hyperfluorescent patterns, and they will present either as classic or occult. Classic is well demarcated. They are easily discerned during transit, and there's late leakage. Whereas there are two major areas where occults can be described. That's fibrovascular PED, where there's irregular elevation of the PED. The boundaries are not well demarcated. The speckled appearance rather than a uniform hyperfluorescent appearance that we'll see on classic membranes, and then leakage of undetermined source is also classified as an occult. So let's look at this. This is a man with age-related macular degeneration, class exudative. You can see the drusen. You can see the drusen there, and you can see the hemorrhage in the center. And when we do the fluorescein angiography, first of all, you see that the hyperfluorescence increases with the phase of the angiogram 1, 2. It fills in a cartwheel or a lacy pattern, and then when you look at this whole lesion, most of it has uniform hyperfluorescence, and that is why we say this is a classic. And because it affects the fovea, this is a classic subfovea or a predominantly classic subfovea choroidal neovascular membrane. So let's look. Occults are usually, this is not an excellent example of an occult, but they are usually speckled. They have this speckled appearance rather than the uniform hyperfluorescent appearance that classic membranes have. Let's look at this classic membrane again. You can see the drusen, see the hemorrhage. Look at the increase in hyperfluorescence as the frame of the continues, and you can see that most of it has a uniform hyperfluorescence, and it affects the center of the fovea. So this is another classic subfovea choroidal neovascular membrane. You can say it's predominantly classic because there are some other areas beside it that are more speckled, but this is a predominantly classic subfovea choroidal neovascular membrane. These days, it tends to be less and less important for us to classify into classic and occult, because in those days it's important in interventory treatment we give, but today either it is predominantly classic or it is not. We are going to be given anti-VEGF. There's another disorder that is more common in Africans. It's called the polypoidal choroidal vasculopathy. We can actually see it on FFA, although the test for a PCV is ICG, the signing green angiography. But this is one of my patients. In the left, she had a PCV. When I did the FFA, this is an FFA, it showed this abnormal branching. If you look at the image in the inferior, in your left and down, you see that there's actually abnormal branching of vessels within the choroid that was obvious by the time, and this right eye looked in an excellent state, but the FFA show us this. So we can still get a lot of information about PCV on the FFA, and although this is it, the hyperfluorescence spots can be seen. ICG is the best to give us information, but we can get information on the FFA. Central serous chorioretinopathy has also, this is the SLO image. You can see this central area of elevation. Here too, you can see on the fundus, and this is an ink blot appearance. And when you see the OCT, it confirms it. Also, this is a smokestack. It's better described the smokestack. You can see the area on the image on your right. You can see the area of central serous retinopathy, and you can see is in the smokestack. So the presentation can that be an ink blot here or a smokestack here, and both of them do happen in central serous chororetinopathy, cystoid macular edema, when there are fluid filled cells in the outer plexiform and inner nuclear layer. Sometimes they could, when they are long-standing, progress to lamella or full thickness hole formations, and these are the causes of CME, retinal vein occlusion by diabetic retinopathy. Post-cataract is called an eye gas. You can see this an ACIL, you can see the hyphema too, and then also intermediate uveitis. These are just the more common causes. And what do we see on FFA? We see there's a parafoveal leakage, and it gives a pattern where there's a late pulling of the dye in a flower petal pattern in the fovea, and that is diagnostic of cystoid macular edema. Proliferative sickle cell retinopathy, you can do a fluorescein angiography and see the dye leakage. Usually the initial teaching was to do the laser and then come back after about 3 months to repeat the angiography and see if the vessels are still leaking or not. So this is also sickle cell, a lot of fibrosis, but when we do the FFA, we can still see the leakage of dye and the abnormal patterns just to confirm that this is proliferative sickle cell retinopathy. Myopic maculopathy, different characteristics we can see in the macula. You can see the atrophic pattern, the lacuar cracks, the macular hemorrhages, and the Fuchs spots. The important thing is that the FFA demonstrates choroidal neovascular membrane as a plaque-like elevation with pigmented halo and sharply defined borders. That's a characteristic of choroidal neovascular membranes that we see on FFA in myopes, and they are quite highly responsive to anti-VEGF, so it's important to make this diagnosis early. Telangiectasia too can also, the different types, parafoveal, Coast disease, Leber's Miller. So we have telangiectasia. FFA can give us the leakage patterns in the area, in the parafoveal area. In inherited retinal disorders, one of the most easy ones to use an FFA to determine is Stargardt disease or Fundus flavi maculatus. They are usually autosomal recessive, present in the 4th to 5th decades of life. Prognosis is better than in Stargardt, and then they usually have this atrophic maculopathy appearance with a lot of flex. We call this flex. And this is what happens when we do an FFA. Sometimes those flecks can be hyperfluorescent, sometimes they can be hypofluorescent, but the characteristic appearance we get, these are other causes of flecks. Retina of Candori, optic disc maculopathy, Stargardt, benign fleck retinopathy, Fundus punctatus, Alport syndrome. All these can cause flecks, but I want us to show. So the flecks, this is a patient of ours that has Fundus flavi maculatus, and we can see the flecks, the yellowish pisiform lesions. We can see the atrophic appearance in the center of the fovea, and this is what is called a dark choroid appearance, because the flecks are obstructing the fluorescence of the choroid from showing well. So we can see that the underlying choroid that normally shows some degree of fluorescence on fluorescein angiography is obstructed, and this is what is called a dark choroid appearance. It is almost pathognomonic of Fundus flavi maculatus or Stargardt disease. Another thing we see here is what is called the bullseye maculopathy. You can see the appearance on fundoscopy. You can see the central hyperpigmentation and the peripheral around it that shows RPE atrophy. When you do an FFA, you can actually see the hypofluorescent center and the hyperfluorescent, which forms the description of bullseye maculopathy, and there are many differentials of that: beaded beetles, Leber's emarosis, Patins, cone dystrophy. And queen is also a differential of bullseye maculopathy. This is also a patient with window defects. You can see the center here, there's RP atrophy. And when we do the fluorescein angiography, you can see that those atrophic areas, they show as hyperfluorescent appearance. So these are just the basic principles of fluorescein angiography and how to do your basic interpretation when you see an image. I always emphasize that fluorescein angiography, we don't treat angiographic scan, we don't treat OCT scans, we treat patients. It's a good investigation, not standalone, but it gives us a lot of information and can help us in managing patients and in making more accurate diagnosis. So look at idiopathic premacular fibrosis, also what is called macular pucker or cellophane maculopathy. On FFA, you can actually see more of the wrinkling in the area, and you can see the vessel tortuosity much better than you would on just a fundus photograph. Wide field angiography is now very much available in many places, and it helps us to be able to diagnose a lot of disorders that hitherto we were not able to identify. Some of these machines are based on confocal scanning laser ophthalmoscope images, and they're able to see all the 360 degrees from the mid periphery to the periphery. And it's very important because, for instance, in vein occlusions, we're able to see a lot more ischemic appearances than we will see with only the center that is shown in the routine fluorescein angiography. And also we can see in the periphery things like Coats disease. If the image was taken only in the center area, this outer area of hyperfluorescence and abnormal vasculature would not be seen very well. Also in retinopathy of prematurity, there are new wide field, ultra wide field fundus fluorescein angiographies that can be used to detect the changes in the periphery of these patients. Of course, this has to be done in conjunction with the pediatricians because this is something you have to calculate the dose right before the infant is given. So, in summary, fundus fluorescein angiography provides good baseline information about retinal vasculature. It's a useful tool for retinal evaluation, and it's still relevant in modern ophthalmology. Thank you for spending your morning to listen to this brief lecture. I will take questions before we close. Thank you.
Thank you very much, Dr. Derilo, for taking your time to give this lecture. We will now take our questions session. If you have any question, please raise your hand up or feel free to type it in the chat box. Okay, we have a hand up. Dr. Harriman has a question. Please go ahead, ma'am. Please unmute your mic and go ahead, ma'am.
Dr. Thank you very much for.
Thank you, ma'am.
Oh, okay. I don't know if you can hear me. Can you hear me? Okay, you can't really hear me. I'll type it.
Okay.
I'm muted, but it seems you can't hear me. Okay, I'll type it. I'll type it.
Does anyone have any questions for Dr. Denrilo? You can raise your hand, unmute your mic and speak, or you can type your questions in the chat box.
So all these lectures are actually, all the KHEFA Retina lectures are available immediately after, I think 72 hours, we'll send you a YouTube link for all the lectures, including the Fundus series, so that if you want to listen to them all over again, you can do that.
I'm sorry, there's a question in the chat box that says how early does one do a FA in cases of CRVO? From Dr. Harriman, how early does one do a FA in cases of CRVO? I hope I got that right.
Okay, yeah, thank you, Ma. So one of and I know why that question is asked. If you do the FFA very early, because of the hemorrhages and the flame-shaped hemorrhages, the information may not be so much. However, in the definition of ischemic, because basically what we are trying to do is to find out if the CRVO, if it is ischemic or not. So when we look at the definition of the ischemia, I'm trying to show that up now so we can see it. It helps us to immediately from the clinical presentation to know which disorder is, which one is likely to be an ischemic CRVO and which one is less likely to be. So based on that, that's one of the things that will guide our decisions on when to do the angiography. The example that I actually showed here is a non-ischemic CRVO, and in such cases, the hemorrhages are not so overwhelming. And so in non-ischemic ones, one can do it at presentation, and you will get adequate information. You'll be able to really assess if this is non-ischemic or not. And it will also help you to, because non-ischemic CRVOs can actually convert to ischemic CRVOs. So once the most information you get is in the non-ischemic ones, and it helps you to be able to follow it up. But for the ischemic ones, already if you apply this criteria, take out the FFA, all these other criteria, without the FFA, you'll be able to know that this is an ischemic CRVO, and then you start to manage it like that. So basically, most information you get from FFA is for non-ischemic, and you can do the FFA at presentation as early as possible, and for the non-ischemic, you will get adequate information on FFA. For the ischemic is shouting I'm an ischemic from the visual acuity, RAPD, extensive intraretinal hemorrhages, multiple cotton wool spots. It's already shouting at the doctor that it's an ischemic, and so it has to be managed like that. But for the non-ischemic is the one that I consider FFA should be done very early. For the ischemic, you might wait until at least a significant amount of the flame-shaped hemorrhages have cleared before you do an FFA that will give you adequate information. But even without the FFA, the ischemic is already shouting, and you know it's an ischemic vein occlusion.
Thank you very much, sir. We have another question from Dr. Latifa Oshunkoya. First, she says, thank you for the beautiful presentation, sir. Kindly explain the key features that helps to differentiate CNV from PVC in patients without FA. Thank you for the beautiful presentation. So she's asking, kindly explain the key features that helps to differentiate CNV from PCV in patients without FA.
That differentiates choroidal neovascular membranes and polypoidal choroidal vasculopathy. Is that the question? Hello?
The question says, kindly help.
Part is there. That's why I'm asking her to clarify.
Okay, sir.
Yes, sir.
Okay, so first of all, I say that when we evaluate a patient, we should try not to just use only the investigations to assess the patient. There's a history. So you know disorders that can have choroidal neovascular membrane, we've mentioned some of them: age-related macular degeneration, myopic, pathologic myopia. So we've mentioned those ones that can have choroidal neovascular. So starting from the history, you have an idea of what it can be. But let's just go straight to the fundus appearance. So usually in choroidal neovascular membranes associated with either myopia or age-related macular degeneration, you will see other features in the retina. In ARMD, you will see drusen. You will see RPE changes. In myopia, you will see the pathologic myopia changes in the back of the eye. Well, most of the time, although sometimes you might not see. And then the appearance of the abnormal vessel, usually, if you look at the images that I showed, you will see that there is in the ARMD, choroidal neovascular membrane, they are sometimes associated with fibrous tissue, in addition to UC drusen and RPE changes. Whereas in PCV, most of the time you are just going to see an orange lesion, an elevated orange lesion close to a vessel. I say close to a vessel, it is actually a choroidal vessel that has formed a polyp, but because the vessel you are seeing is a retinal vessel, you are going to see an abnormal elevation or hemorrhagic appearance close to the retinal vessel. It's really underneath the retinal vessel. So, and then when you look at the age range and that the fact that there's usually no drusen or any of those other pathological changes that you see in pathologic myopia, then those are the ones that will raise the suspicion that this is likely a PCV and not an ARMD, choroidal neovascular membranes. There are other factors, like especially if the PCV has bled. The PCV usually they have huge bleeds, but generally the age of presentation of patients PCV is usually younger compared to exudative ARMD. So you have to avail yourself all the information starting from the exam, from the presentation to the examination, to be able to make the right diagnosis before you now do an FFA. And then of course, you know, the FFA will show you if it's ARMD, it's going to be either classic or occult. If it's PCV, you are not definitely going to see a classic, although there have been presentations where they've seen both patterns, but most of the time you see an isolated hyperfluorescent area close to a retinal vessel. It's either going to be peripapillary for PCV, or there are some that are actually paramacular. Okay, I hope I helped and I didn't increase the...
Thank you, sir.
Okay.
Thank you, sir. I don't know if anyone has any more questions before we round up. If you have any more questions, the session is coming to an end. You can please type your questions or raise your hand. In the absence of no more questions, I would like to thank everyone for taking the time to join us. The Vitreoretinal series lecture is going to be taking place first Wednesdays of every month. We'll send out the invitations, so you can please make out time to join us every first Wednesday of every month, 8 a.m. to 9 a.m. As Dr. Derilo has said, we're going to be having a mixture of speakers going forward. Both local and international faculties will be taking us in various lectures throughout the year. Thank you once again, Dr. Derilo. Thank you very much.